Hi, everyone. Thank you all for coming out. My name is Fabiola Lozano, and I'm one of the PGY1 residents here at Erlanger. Today, I will be talking about the heartbreaking updates on the use of aspirin for primary prevention. So first, I want to start off by stating that I don't have any personal, financial, or professional conflicts of interest regarding the information that I will be talking about in this presentation. We'll start the presentation by reviewing some background information and some historical studies that led to the role of aspirin in primary prevention. Then we will compare some previous and current guideline recommendations along with the most up-to-date evidence. And then along this presentation, I'll introduce some patient cases as well that will serve as the learning assessments at the end of the presentation. So let's start off by reviewing some background. So the fascinating story of aspirin dates back to 3,500 years ago when willow bark was used as a painkiller by the Egyptians and then by physicians from ancient Greece and Rome. In the 19th century, researchers began to extract and synthesize aspirin precursors known as salicylates for their antipyretic effects. And then it was commercialized in 1899. And then in 1970s is when we began to discover its potential role as an antithrombotic. So just a quick review of its mechanism of action. So aspirin irreversibly inhibits both cyclooxygenase 1 and 2, or COX-1 and 2, but the antiplatelet activity is driven primarily by COX-1, and this blocks the production of prostaglandins such as thromboxane A2, which ultimately decreases platelet activation and aggregation. So here we see what that platelet inhibition looks like on a larger scale. So that irreversible inhibition of COX-1 prevents platelet aggregation. And then as you can see right here on the right side of the image, essentially prevents further accumulation onto an atherosclerotic plaque. So this ability to deliver platelet inhibition and slow down the process of atherosclerosis is what contributes to aspirin's potential role in preventing thrombotic events in patients with cardiovascular disease. And this process doesn't occur overnight. It's often a result of years and years of exposure to certain risk factors like uncontrolled diabetes, hypertension, dyslipidemia, and inflammation. These factors trigger the formation of fatty streaks, which are the hallmark in the development of an atherosclerotic plaque. And through a complex series, which involves accumulation of platelets, monocytes, and lipoproteins, you get this plaque formation. And so platelets really play an anti-inflammatory role and are the key mediators in this entire process. And while most plaques usually remain asymptomatic, which is considered subclinical atherosclerosis. Once the plaque ruptures, platelet-rich blood clots are immediately formed and they block the vessels, which lead to ischemic thrombotic events such as MIs or heart attacks, strokes, or peripheral vascular disease. So therefore, aspirin's antiplatelet effects and properties make it an ideal agent to slow and prevent the progression of this atherosclerotic plaque formation, thus preventing cardiovascular events. So now we'll get into some of the historical studies which have explored aspirin's cardiovascular protective benefits. In 1974, we had the first trial that showed potential reduction in deaths among patients with a recent myocardial infarction. This study was really what ignited interest in the discovery of aspirin's role in preventing a secondary cardiovascular event. And it's known as a Cardiff-1 trial, and it aimed to evaluate whether aspirin prevented deaths in men who had a recent MI. And it was a randomized controlled trial in 6 different hospitals in South Wales, UK. They included over 1,200 patients that had recently been discharged with a diagnosis of an MI. Those who were on anticoagulation or had a history of peptic ulcers were excluded. And then the patients that were included were randomized to receive either aspirin 300 milligrams daily or placebo, and they were followed for an average of 12 months. So initially, cardiovascular deaths was the primary outcome. However, because they were unable to determine whether the deaths or the cause of death was related to cardiovascular causes, they ended up drawing conclusions from total mortality. And so what they saw is that aspirin resulted in a 25% reduction in the risk of death after an MI. And most of the side effects were mild, non-serious. However, these results were non-significant. And even though the results were not statistically significant, the Cardiff 1 trial ultimately ignited a series of trials that were further exploring its potential role in secondary prevention. And then also these trials that followed the Cardiff 1 trial were inconclusive. However, in 1985, the FDA ended up approving aspirin for secondary prevention based off of results of a meta-analysis of these inconclusive trials. And so what they found was that the combined results of the trials showed that aspirin significantly reduced the risk of vascular death by 15% in those with the previous cardiovascular event like stroke or MI. So the Health and Human Services Secretary at the time announced that the FDA concluded that taking 1 aspirin per day was safe and an effective way to prevent heart attacks in people who already had one. But she also noted that the studies didn't assess whether healthy patients would also benefit, but that many physicians routinely took one, so safe. The FDA approval ultimately sparked enthusiasm to further explore and investigate whether aspirin might be effective for primary prevention of a cardiovascular event. And then within just a few years after that approval, a series of randomized controlled trials arose, which included the British Doctors Study, the Physicians' Health Study, the Thrombosis Prevention Study, Hypertension Optimal Treatment Study, and the Primary Prevention Project. So the first large randomized controlled trial exploring the role of aspirin for primary prevention was a Physicians' Health Study of 1989. And the purpose of the study was to determine whether low-dose aspirin decreased cardiovascular mortality. And it was a randomized, double-blind, placebo-controlled trial of over 2,200 male physicians between the age of 40 to 84 without a prior stroke or MI, so fairly healthy males. And they were randomized to receive either aspirin 325 milligrams every other day or placebo. And results from the study showed that over a median of 5 years, aspirin did not reduce cardiovascular mortality. However, there was a 44% statistically significant reduction in the risk of an MI and also a slightly increased risk of a hemorrhagic stroke, which was not significant. And there was also a significantly higher risk of bleeding in those who were receiving aspirin. And then as you can see here, for the results that are statistically significant, I have color-coded them. So those that are positive are color-coded in green. And then those that had a negative outcome are color-coded in red. So the Physicians' Health Study showed that aspirin significantly reduced the risk of a first MI. Additionally, in a subgroup analysis that they conducted, there was a greater benefit seen in those over the age of 50. While there was a higher risk of bleeding and hemorrhagic stroke, authors ultimately reported that the evidence concerning these adverse effects remained inconclusive because of inadequate numbers of physicians with these events and endpoints. And shortly after this study, several studies followed in the footsteps of the Physicians' Health Study, and they were also further exploring whether aspirin had a potential role to prevent a first cardiovascular event. So these studies that followed the Physicians' Health Study ultimately shifted to focus on lower doses of aspirin and in groups or patients who were at a higher risk for cardiovascular disease. So we already talked about the Physicians' Health Study. Once again, I've color-coded those statistically significant results in either green or red. The thrombosis prevention trial of 1998, which evaluated whether low-dose aspirin would prevent ischemic heart disease in men at high risk for cardiovascular disease, found that aspirin significantly reduced the risk of an MI. That same year, the Hypertension Optimal Treatment Study, or the HOT trial, revealed that there was a reduction in risk of major adverse cardiovascular events, or MACE, and MI in patients with hypertension taking aspirin, but there was also an increased risk of bleeding. And then we have the primary prevention project of 2001, which included individuals with more than one cardiovascular risk factor. And they found that aspirin increased the risk of severe bleeds, but there was a significant reduction in cardiovascular mortality. So similar to the physician's health study, most of these studies suggested in a reduction in the risk of a first heart attack, but at the cost of increased bleeding, even with lower doses of aspirin. Unfortunately, the results of this study were not convincing enough to gain FDA approval. However, despite the FDA denying aspirin's approval for primary prevention, in 2002, the U.S. Preventive Services Task Force provided their recommendations to initiate aspirin in patients with a high risk for coronary heart disease, which included patients over the age of 40, postmenopausal women, and younger adults with risk factors such as hypertension, diabetes, or a current history of smoking. That same year, the American Heart Association also released their recommendations, basically agreeing with the recommendations of the USPSTF to initiate low-dose aspirin in those with a high cardiovascular risk. So let's take a quick break from some of this historical literature to meet some of our patients. And as I present them, I want you all to start thinking about whether aspirin would be appropriate to initiate or if it's appropriate to be on. And then we'll revisit them again towards the end of the presentation. And as I present some more literature, I just want you to think about whether your initial decision would change or not. So first we have Miss JJ. She is a 52-year-old Black female. On rounds, the medical resident is suggesting that he wants to start aspirin 81 milligrams daily after calculating a 16% cardiovascular disease risk score. Next, we have Miss TJ, a 71-year-old Caucasian female. She has been on aspirin for 20 years and recently saw a TikTok about the dangers of aspirin and its risk of increased bleeding. She's asking if she should stop taking aspirin. And then we also have Mr. FM. He is a 47-year-old Hispanic male. He recently saw on Despierta America, or the Latin version of Good Morning America, the diabetics are in increased risk for cardiovascular events and is asking if he should start a baby aspirin. And then finally, we have Mr. CC. He is a 42-year-old Caucasian male. While reviewing his medication list as you prepare for his diabetes management appointment at the UTFP clinic, you notice a prescription for aspirin 81 milligrams on his profile. So now back to the rest of our evidence. The 21st century brought on major advancements in cardiovascular disease reduction, such as an emphasis on smoking cessation, lifestyle modifications, and widespread evidence prescribing of statins, but also reignited interest in aspirin for primary prevention with additional major trials that were further investigating the use of aspirin in several population types. The primary endpoint for most of these studies was a reduction of a major cardiovascular event. And although aspirin did not significantly reduce MACE in these studies, we did again additionally gain insight into its potential role in specific populations. And so once again, for your reference, statistically significant results are color-coded. So first we had the Women's Health Study of 2005, and aspirin, 100 milligrams of aspirin every other day reduced the risk of a stroke, but also increased the risk of a GI bleed. In the POP-ADAD trial, or the prevention of progression of arterial disease and diabetes, they focused on patients with diabetes with mild peripheral arterial disease, and they found no differences in the studied outcomes. Similarly, the Japanese primary prevention of atherosclerosis with aspirin for diabetes showed that aspirin in those that were aged 30 to 85 with type 2 diabetes did not significantly reduce a composite outcome of atherosclerotic events, but it did reduce CV mortality. However, the results were 1 person in the aspirin group versus 15 in the control group. In the aspirin for asymptomatic atherosclerosis trial, there were no differences in the studied outcomes. in those with mild peripheral arterial disease. And then finally, in the Japanese primary prevention study, which included elderly patients with multiple risk factors, they were unable to prove any benefits of aspirin in the primary outcome, but there was a statistically significant reduction in the risk of an MI, but at an increased risk of extracranial bleeding. And so the results of these studies ultimately led to a statement that was released by the FDA in 2014 addressing the use of aspirin for primary prevention. And so they did not believe that the evidence supported the use of aspirin for primary prevention of a heart attack or stroke based off of the available data from those recent trials. And in fact, there were serious risks associated with the use of aspirin, such as an increased risk of bleeding. The FDA stated that the available evidence supported the use of aspirin for preventing a second or another heart attack or stroke because the known benefits in this population outweighed the risks. So the results of these studies and the FDA statement ultimately led to variable and inconsistent recommendations from several national organizations. In 2012, the American College of Chest Physician Guidelines recommended the use of aspirin for all patients over the age of 50, regardless of age, gender, or the presence of diabetes. In 2014, the American Heart Association and American Stroke Association guidelines recommended low-dose aspirin to prevent a first stroke among women, which included those with diabetes, those with a high risk for cardiovascular disease, and also those with chronic kidney disease. In 2015, the AHA, ADA, or American Diabetes Association, recommended aspirin for those with diabetes and a 10-year cardiovascular risk above 10%, as long as they had a low risk of bleeding. And then in 2016, the USPSTF recommended to focus on those between the ages of 50 to 59 with the cardiovascular risk above 10% and a low risk of bleeding. And in contrast to most of the American guidelines, the European Society of Cardiology actually recommended against initiating aspirin in individuals without an overt cardiovascular disease. So now we'll discuss some of the most recent studies, which led to the updated recommendations the guideline recommendations of these organizations. So our most up-to-date evidence comes from these 4 large randomized controlled trials that arose in 2018. So we have ARRIVE, ASCEND, ASPREE, and the most recent TIPS 3 trial. We'll start with aspirin to reduce risk of initial vascular events, or the ARRIVE trial. And they included patients over the age of 55 with 2 to 4 risk factors if they were male, and if they were women, over the age of 60 with 3 or more risk factors. Patients with diabetes, a history of previous cardiovascular events were excluded. And then most of the patients were at moderate risk based off of the 10-year ASCVD risk that you see above and the Framingham cardiovascular heart disease risk. And so they were randomized to receive either aspirin 100 milligrams daily or placebo for a median of 60 months. And the objective of the trial was to evaluate whether aspirin would reduce the risk of a major cardiovascular event, which was the composite of an MI, stroke, transischemic attack, unstable angina, and cardiovascular death. There were no significant effects in the primary outcome of MACE, MI, stroke, or cardiovascular mortality, but there was a statistically significant higher risk of bleeding, which were mostly classified as mild. So overall, the ARRIVE trial failed to show that aspirin was superior to placebo at preventing adverse cardiovascular events in adults with moderate cardiovascular risk, but there was an observed benefit favoring those patients with a lower risk of cardiovascular, a lower risk 10% and lower. In regards to safety, bleeding events were low and similar between the 2 groups. Therefore, the authors concluded that the use of aspirin in moderate risk patients needs to be individualized. And here, moderate risk was defined as a 10-year risk of 10 to 20% based off of the ASCVD and Framingham risk calculations that you saw. So I'm sure many of you have used this risk calculator at one point in your career or in pharmacy school. And so this ASCVD risk calculator is just a way to quantify a patient's risk of a cardiovascular event over 10 years based off of demographic information, blood pressure, lipid panel, and smoking status. However, some limitations of this risk calculator is that it does require findings and a recent lipid panel, and likely can over or underestimate the risk for certain ethnic backgrounds. And it's not as accurate for patients who are older than 79. Another tool that the ASPREE used was the Framingham risk score, which is used to estimate the 10-year cardiovascular risk, similar to the ASCVD risk calculator. However, there are two versions since it's gender specific, and it doesn't take into consideration whether the patient is on a statin or an antihypertensive like the ACC risk calculator does. And we know that if the patients are already on optimized statin or antihypertensive therapy, it does reduce the risk of a cardiovascular event. Shortly after the ARRIVE trial came the study of cardiovascular events and diabetes, or the ASCEND trial of 2018. And they focused on patients with type 2 diabetes over the age of 40 with no known cardiovascular disease and a fairly controlled diabetes based off of their mean A1C of 7.2. Majority of the patients were at low or moderate cardiovascular risk. And then they were randomized to receive either 100 milligrams of aspirin daily or placebo for a median of 30 months. Primary outcome, once again, was the first occurrence of a serious vascular event, which included non-fatal MI, stroke, or a TIA, or vascular death. And from the results of these studies, we saw that in patients with diabetes, there was a significant reduction in a first serious vascular event by nearly 12%. There was also a reduction in MI and stroke, but they were not statistically significant. There was also a statistically significant increased risk of bleeding, major bleeding. So the ASCEND trial ultimately suggested that aspirin may have a slight benefit in reducing vascular events in patients with well-controlled diabetes. And these findings were similar across all degrees of vascular risk from low to high risk. However, the observed benefits were at the cost of an increase in risk of major bleeding of a similar magnitude. However, unlike other studies, the ASCEND trial developed their own model to determine baseline risk of patients through a Poisson regression model, but it also took into consideration age, gender, smoking status, systolic blood pressure, BMI, so similar to like the Framingham risk calculator. And although they factored in well-known risk factors, the use of this non-validated risk calculator makes it difficult for us to replicate and apply to other patients. So the largest trial that we have is the aspirin and reducing events in the elderly, or the ASPREE trial. And they enrolled over 1,900 patients, healthy elderly patients over the age of 65 without a history of a cardiovascular disease or any other chronic condition that would increase their cardiovascular risk. And they excluded patients that were on an anticoagulant or antiplatelet medications, if they had a systolic blood pressure over 180 or a medical indication or contraindication to the use of aspirin. And the cardiovascular outcomes were actually based off of a secondary endpoint of the study. And then the individual components of this outcome, cardiovascular disease, was then further analyzed in a post-hoc analysis. And the results demonstrated that at a median of 4.7 years, there was no difference in cardiovascular disease, major cardiovascular events, or cardiovascular death between the two groups. However, there was an increased risk of major hemorrhagic events, which included intracranial and extracranial hemorrhage, and there was also an observed increase in all-cause mortality. So ultimately, ASPREE demonstrated that in fairly healthy older adults, aspirin did not reduce cardiovascular disease. And in fact, there was an increased risk of bleeding and possibly increased risk in mortality. The International Polycap Study, or TIPS-3 trial, was the most recent trial, which included over 5,000 patients over the age of 50 with a moderate risk for cardiovascular disease based off of their mean inner heart risk score. So key exclusions included patients with vascular disease, systolic blood pressure under 120, or symptomatic hypotension, peptic ulcer disease, dyspepsia, and bleeding. The components, patients were randomized in a 2-by-2 fashion to receive either a polypill plus placebo or polypill plus aspirin. And that polypill included simvastatin, ramipril, hydrochlorothiazide, and atenolol. So the TIPS-3 trial aimed to determine whether aspirin reduced the composite of cardiovascular death, MI, or stroke. And at a median of 4.6 years, there was a significant reduction in major cardiovascular events and stroke in those who were taking aspirin. And this reduction was primarily driven by that reduction in stroke. Unlike previous studies, there was no difference in bleeding between the patients receiving aspirin versus placebo. So the TIPS-3 trial showed that adding low-dose aspirin to the polypill reduced cardiovascular events at 5 years among patients with a high cardiovascular risk. And low-dose aspirin resulted in a lower stroke risk, and the polypill overall resulted in expected LDL and blood pressure lowering effects, which were expected. High risk was defined here by the inner heart risk score as a 16% or 16 points or above. And we already talked about the ACC-ASCVD risk calculator and the Framingham risk calculator, but unlike previous trials, the TIPS-3 actually used the inner heart risk score. And this was developed by the European Society of Cardiology, and it takes into consideration similar factors like the previous calculators do, so age, smoking status, diabetes, hypertension. And then here you can see the shortened version of that calculator, and scores typically range from 0 to 48, and higher scores or higher points indicating a higher risk of having a heart attack. So unlike the ACC-ACVD risk calculator, there is a version that does not require any labs. The only limitation is translating the results of the inner heart risk score to the percent that we see in Framingham or the ACC-ACVD risk calculator. So in summary, ARRIVE trial demonstrated that in patients with moderate ASCVD risk, there were no differences in cardiovascular events between aspirin and those that were taking placebo. ASCEND showed that in patients with a moderate cardiovascular risk and diabetes, aspirin may be beneficial. ASPREE showed that in patients over the age of 65 or elderly patients, aspirin may actually have an increase in mortality. And then in TIPS-3, we saw that patients at high cardiovascular risk, adding aspirin reduced cardiovascular events. So now we'll talk about how these studies impacted our current guideline recommendations. So we'll start by talking about one of 2022's major guideline updates. Earlier this year, the USPSTF released their updated recommendations for the use of aspirin in primary prevention based off the findings that we saw from these studies. So in these guidelines, they recommend that the decision to initiate low-dose aspirin for primary prevention in those between the age of 40 to 59 who have a 10% or greater risk for a cardiovascular disease should be individualized based off of the evidence that the net benefit of aspirin in this group is small. But persons who are not at an increased risk of bleeding and are willing to take low-dose aspirin are more likely to benefit. The 10-year cardiovascular risk here is defined based off of the ACC-ASCVD risk calculator, and they define that as a risk of 10% or greater. So the updates from 2016 to 2022 primarily focused on the age group. So while previously it was recommended to consider starting aspirin in patients who were between the ages of 60 to 69, now they actually recommend to not use due to the increased risk of bleeding and mortality in this population, as we saw in the ASPREE trial. And in those that are aged 40 to 59 at high risk, you can consider starting aspirin. It's not a clear indication to initiate aspirin. And then so we'll also review some of the other recommendations from other organizations. So the 2022 American Diabetes Association recommends initiating low-dose aspirin in those that are moderate ASCVD risk based off of the findings from the ASCEND trial. However, because of the increased risk of bleeding observed in these studies, clinicians must determine what the benefit versus risk is. And moderate risk here is defined as those with ASCVD risk of 10 to 20%. So similar to the ADA, the European Society of Cardiology also recommends to initiate low-dose aspirin for those with diabetes or a high or very high cardiovascular disease risk, as long as patients are not at an increased risk of bleeding. And in the ESC, their assessment is based off of the SCORE 2 or SCORE for older patients, or OP. And this is very similar to the ASCVD and Framingham risk score. They are risk assessment models that are used to determine the risk of a cardiovascular event over 10 years. And it also takes into consideration smoking status, gender, HDL levels, systolic blood pressure, but then takes a further step, and it's actually calibrated to 4 different European geographical regions based off of cardiovascular rates for those geographical areas. The 2019 ACC/AHA guidelines still recommend low-dose aspirin in those that are 40 to 70 years old with an elevated ASCVD risk. Their advice is to avoid in those that are older than 70 years based off of the findings from ASPREE. An elevated ASCVD here is defined as a risk of 10% or greater. So now one of the more lenient guidelines, which has yet to release any updates, are still the 2012 CHEST recommendations to initiate aspirin in all adults over the age of 50, regardless of age, gender, or diabetes. And this is based off of the studies that were available at the time. They have yet to release an update. So here's just a quick summary of these guidelines that we just talked about. So what we can take from this evidence that we just reviewed is that aspirin should be evaluated for every patient to determine whether the benefit outweighs the risk of bleeding. Aspirin use in those with low cardiovascular risk is not recommended. And those who have a moderate risk, those with concurrent diabetes, may have a greater benefit. And the evidence is shown to really benefit those with the higher cardiovascular risk based off of the data that we saw in TIPS 3. So when we're thinking of who are ideal candidates for aspirin therapy, the optimal age is really for those that are 40 to 59. As we saw in ASPREE, the elderly population may have greater risk of bleeding. Once again, if they're at a moderate risk, other factors should be taken into consideration. And then additionally, aspirin should be initiated in those with a high cardiovascular risk, since we have the most evidence backing up this population. So now on to our patients from earlier. So first we have Miss JJ. So she was our 52-year-old Black female, and the medical resident was suggesting to go ahead and start aspirin. She had a high cardiovascular risk. So she has a past medical history significant for hyperlipidemia, hypertension, and GERD. Home medications include Protonix, amlodipine, and chlorthalidone. And then I've listed her vitals and lipid panel. However, upon a deeper dive into her chart that was scanned from an outside facility, you find that she had a gastric ulcer repaired in 2021 and 2016. So here is her ASCVD risk percentage, plugging in the available information that we had for her. So for this patient, do we start aspirin or should we not? Raise your hand if you think we should start aspirin. Raise your hand if you think we shouldn't. So for her, she does have a moderate cardiovascular risk. So technically does not fit the criteria for those that have a high risk. Some other interventions that can be done is if you wanted to start aspirin, you can also optimize her PPI dose. So making that once daily to twice daily, improving her blood pressure. But what if I told you guys that Miss JJ was a current smoker? So that would actually raise her cardiovascular risk to nearly 30%. So now how many of you guys would start aspirin? Yeah, so she now fits in that high risk population. So aspirin would be appropriate, just keeping in mind that history of her GI bleed that she had. But like I just discussed, there are other interventions that you could also take to minimize her risk of bleeding. So now Miss TJ, she is our 71-year-old female who watched a recent TikTok about the increased risk of bleeding. And she was asking if she should stop aspirin. Her past medical history includes GERD and hyperlipidemia. She only takes Crestor aside from aspirin, and her blood pressure is well controlled. Her ASCVD risk after plugging in the available information comes out to 8.7%. So she is in that intermediate borderline range. So do we stop aspirin or do we keep it? How many of you guys would stop aspirin? Anyone want to keep aspirin? So for Miss TJ, there's really no recommendations for discontinuation of aspirin therapy. As we saw in the studies and in the guideline recommendations, they address the initiation of aspirin, but not discontinuation of aspirin. For her, her cardiovascular risk is not high, and she really doesn't have a risk of bleed either based off of her past medical history, aside from her age. So it probably wouldn't hurt to leave her on aspirin, but really, as we saw in the ASPREE trial, there was a higher risk in the elderly population, and there's a possible increase in mortality as well. So the decision to stop or continue therapy would really be driven by the fact that it's just one less pill for her to take. So now Mr. FM, he is our 47-year-old Hispanic male, and he is asking if he should start aspirin based off of what he saw on Despierta America. So his past medical history, aside from diabetes, includes hypertension, and then he occasionally drinks beer on the weekends. He is on lisinopril, metformin, and Jardiance. Blood pressure fairly controlled, and above is his lipid panel as well. His ASCVD risk is 5%, so fairly low. However, as I mentioned earlier, the ACC ASCVD risk calculator may overestimate the risk for certain populations. So for Hispanics, like Mexican Americans, it tends to overestimate it. To further assess his risk, we can use the inner heart risk score calculator that we saw in the European Society of Cardiology guidelines. His total's up to 8, so he falls into the low risk of cardiovascular disease. So for Mr. FM, raise your hand if you think we should start aspirin. Oop. Raise your hand if you think we should not start aspirin. Yes, so for Mr. FM, so although he does have diabetes, his overall cardiovascular disease risk is fairly low. And so as we saw in the ASCEND study, diabetes alone is not an indication unless they are at a moderate or high risk for cardiovascular disease. Some other options that you can take or implement to reduce his risk of a cardiovascular event would be optimizing blood pressure and diabetes, as well as recommending lifestyle modifications. So last but not least, we have Miss CC. She is our 42-year-old. He is our 42-year-old male with a past medical history of diabetes, hyperlipidemia, and GERD. He reports that he smokes about 7 cigarettes a day, which is down from his previous 1 pack a day. Medications are listed above. Is Mr. CC appropriate to continue on his aspirin therapy? Raise your hand if you would leave the aspirin on his profile. Raise your hand if you would stop aspirin. So for him, his ASCVD risk falls into the borderline of intermediate and moderate or high. His risk is 10.4%. And then just to point out, if he was not a smoker, his ASCVD risk would be significantly lower. So from 10.4 to 3.5. So Mr. CC is an appropriate candidate for therapy. So unlike Mr. FM, he would be indicated for aspirin. He is a diabetic, but also has a high ASCVD risk. And then some additional interventions that could be emphasized is to also decrease his risk of cardiovascular event would be emphasizing smoking cessation. So some key takeaway points once again, aspirin is not a one-size-fits-all therapy, and aspirin use may be beneficial in preventing cardiovascular events in those at high risk for a cardiovascular event. And those with a moderate risk, other factors should also be taken into consideration. And finally, we should always keep in mind that risk of bleeding. So choosing whether or not to initiate aspirin at the end of the day is really risk benefit and should be patient specific. That is all I have for today. Does anyone have any questions? Yes, Megan?
I really don't use, but I noticed when you pull up the screenshot that whether or not the patient went on aspirin is a part of the calculator itself. So how much does that contribute to the risk? And how does that influence aspirin itself?
So I don't know exactly the percent that it increases that risk by, but that is taken into consideration that most likely if they're already on aspirin, they've probably had a prior cardiovascular event. So when you're thinking about whether aspirin is appropriate, well, they might be on it already because of that MI. And so we know that in secondary prevention, aspirin is indicated. So, but I can double check and play around with the calculations and see how much that would either increase or decrease the risk. Yes, Brittany?
I do have a question. I see a lot of patients both in the medication setting on aspirin for like their primary prevention reasons. Oftentimes my team is not really confident in because we're not their primary care provider. But you did mention use or basically augmenting their stress ulcer prophylaxis therapy. Yeah, prophylaxis. I wonder what evidence you came across. Is there any specific information about twice daily diagnosing? So are there data to support that or any formal recommendations for how to add acid suppressant therapy?
So the question is if there is any available evidence about adding on acid suppressive therapy for patients who are not likely candidates for aspirin use. So from what I found, the studies did not assess whether the patients were already on stress ulcer prophylaxis or if they were on a PPI or an H2 receptor agonist. That is one of the gaps in literature. So I think future studies could look into that and study what the role of optimizing those medications. At the moment, I did not come across any studies that were evaluating that.
The reason I ask is because there's also now a plethora of literature suggesting that doses of proton may also contribute to long-term health effects. And so I just wondered if that thought about increasing their PPI was something across the literature or something that should be a general consideration in that patient.
Yeah, I think from what I read, most of the studies were alluding to that being a limitation. So I think in the future, there is a role to investigate what the role of that is. Yes.
Does it currently use guide providers from deciding whether
I do not think there's a formal protocol or anything in place. I think from my experience, it's just based on whether the clinician or whoever is evaluating the appropriateness, but we do not have a protocol in place, at least not one that I know of, unless Lacey, if you. Brandy?
One question, any of your patients, for instance, if any of them also had hypotonic fibrillation and were already on warfarin or Isoac, would that change your recommendation?
That is a good question. If patients were already on anticoagulation for another indication like atrial fibrillation, let me look into that. I know there's recommendations on that. I'll look into it. Any more questions? All right, well, here is what you guys are waiting for, I'm sure. Thank you all for coming.